Todo listo, doctor Boris, ya podemos comenzar.
Creo que todavía no están todos dentro, ¿no? ¿Ya están todos dentro? Sí, ¿verdad? Ok. Bueno, vamos a comenzar. Pues bienvenidos todos al seminario en computación del Centro de Estudios en Computación Avanzada. Tenemos un invitado muy especial y voy a cambiar el idioma de la plática a inglés para que nos entienda el profesor Luc Duong. So welcome everyone to the seminar. We have in this time, in this occasion, a very important and interesting speaker. And I thank very much Professor Duong for accepting to lecture this talk in this seminar. Thank you very much. And before we start, I'm going to present uh, Professor Duong's short biography. Professor Luc Duong completed his PhD in 2007 at École Polytechnique de Montréal. His thesis topic focused on machine learning approaches to guide operative strategy in correcting scoliosis deformities. Then he was a postdoctoral fellow at Siemens Corporate Research in Princeton, New Jersey. At Siemens, he worked on a project for navigation assistance for coronary arteries with chronic total occlusion. Since 2009, Professor Duong has been teaching at École de Technologie Supérieure, and he's mainly interested in image analysis, computer vision, and machine learning. He works closely with cardiology department of CHU San Justin, Children's Hospital, I believe, in projects related to interventions for congenital heart disease. So thank you very much, Professor Duong, for lecturing this conference, and please, you can start wherever you want.
Thank you very much, and thanks to Boris and Jimena for inviting me. It's a great honor and pleasure to speak with you, and I am very thrilled to see the amount of people joining for the talk. It's greatly appreciated. So without further ado, we'll start with the presentation. This is more a visual abstract of the content of my talk. So you will see a lot of things. I apologize in advance, but I am going to be I'm going to try to be as concise as possible. And so feel free at the end if you have any questions, different projects that we have done during the course of the years. I'll be glad to talk a little bit more about specific projects. So what we do at the lab, our main topic is to study cardiorespiratory motion compensation, as you can see here. And we are trying to harness the cardiac and respiratory motion during interventional cases. So in cardiology, you do have open heart surgery when you have to open up the patient and go inside and assess the vascular structure, but you can do also to do it minimally invasive with catheter. So you insert a catheter inside the patient and you access the vascular structure. You inject contrast agent to see the vascular structure. And with that, you can treat without even opening up the patient, which is very good for the patient instead of, it has very low it has better chances of recovery. But to do that, we need to have imaging, which is the topic of my talk. So we use X-ray angiography to guide, and you can see here, you can see two different imager from two different sides that allows the interventional cardiologist to assess the vascular structure to treat, and then to go, for instance, to put a stent, as you can see on the left. So you can put a stent inside. We have done some work also with intravascular imaging, such as optical coherence tomography, which allows us to see inside the vessel. But I will talk more about all those projects, and I will talk a bit about how to use virtual models, or how virtual models can help us understand a bit more how to navigate into cases in cardiology. So first of all, I'd like to talk a little bit about what we're working on. We're working mostly with patients with congenital heart disease, which is very complex. It affects 1.5 million children worldwide. And the first line of defense, of course, it's to use catheter-based intervention because it's children. Usually they have a few weeks old only. So it's better to use minimally invasive procedures first if we can do it. However, it's more challenging to treat than adult because it's a smaller scale. The patient has a higher heart rate. Also, like the congenital heart disease mentioned, it has irregular vessel shapes or vascular or anatomical structures are very different. It's still developing and so on, and we have malformation. So it's very challenging. One anecdote I can tell you is I was used to work in adult cardiology, but when we went to work on the pediatric cases, we had the difficulty in the CT scan to find the aorta. Usually the aorta is the most easiest structure to see in the CT scan. But in the CT scan of the pediatric patient, it was really tough for us to adapt our knowledge of the adult anatomical structure to the smaller shape of pediatric patient. So congenital heart disease is not a problem related with lifestyle, of course, but it's mostly due to congenital defects. You have all sorts of defects, which makes it a bit complicated to work all over the place. But you have cases where you have pulmonary stenosis. You can have aneurysm in the coronary arteries, such as in Kawasaki disease that we did work on it. We have also all sorts of holes or defects, such as atrial and ventricular septal defects, etc. In my opinion, it's one of the next frontier in cardiology. Of course, there are some interesting work in all the different adult cardiology specialty, but I think it has a lot of impact since it might explain a lot of adult-related condition. Since we don't know for some cases that you have some patient that at one point will develop some problem in his life, but usually it's because it had congenital heart disease before. So it's important to assess, I think, and to be able to follow up children at a young age that we are suspecting that they might have CHD, because we want to avoid that it's going to go to the adult and that it's going to be more severe. So that's why it's, in my opinion, it's a field very interesting to go. So X-ray angiography, I explained a little bit before what it is. It provides navigation guidance. Usually you have 5 to 15 frames per second in terms of video. So you can see here the X-ray angiography of a right coronary of a 3-year-old patient. So you can see the heart is moving quite fast. It uses also the smallest catheter possible. It's a 4 French catheter of 1.3 millimeter diameter. So that gives you an idea about the small size of the vessel that we're currently seeing on these images. We are currently installing, I think, a new system at St. Justine Hospital, which might allow us to have a higher frame rate, which might allow us to see better the coronary artery and so on. So we're looking forward to that. Our idea at the lab is to be able to provide augmented reality and to have all sorts of models that we can use in 3D and to allow the cardiologist to see their model. Right now, they're only working with the computer screens that are inside the cath lab, but I think that might be useful at one point to have augmented reality view of the surgical field and to be able to view the patient-specific models and to be able to do, for example, modeling or fitting of stent directly within the patient frames. to have all the cardiorespiratory modeling all integrated into specific views, and to be able to do, for example, fluid simulation or finite element simulation with the 3D models, and to be able to use it and visualize it using augmented reality or virtual reality headset. We were lucky to be one of the first to have the HoloLens 2 in Canada, and we have now a Vision Pro by Apple to display the model, and we're currently now doing a study to evaluate what is the accuracy with the Vision Pro. With the Vision Pro, what is nice is that it allows us to have the user's high tracking already integrated into the 3D display. So I think there is a lot of things that we can do with that, and we can also understand a bit more how the cardiologist is viewing the scene, and how can we improve, his senses, so he can do a better performance in the cath lab. So that's our main, topic that we're working on in the lab. One of the first work would be to do the calibration with the system. I showed you the X-ray angiography. However, the system itself, although in the DICOM images, there are the parameter of the imaging system embedded into the DICOM files. But usually when you take those parameters, it's not the full calibration information. It doesn't mean that the system is not precise. That just means that what is inputted into the DICOM files, it's basically what an approximation of the source to intensifier distance. Also, it has the angles of rotation, but those angle of rotation, usually they're not as precise as they would like to be if you want to do 3D reconstruction. So our goal was to first do the calibration of the system. We had the calibration object that we printed in 3D with tungsten beads inside. And with those tungsten beads, that allowed us to reconstruct in 3D from 2 views and to calibrate the system. However, the calibration was good. It was a bit limited, and it's not really the type of calibration we really wanted, because we wanted to have a calibration that is really local to the structure that we want to reconstruct in 3D. Because if we want to display it into augmented reality, we need to have a very precise one. So what we did is that we say, well, maybe we should use the catheter, since the catheter itself, it's manufactured with a very, very high accuracy. We could use the catheter size to calibrate, to do like a calibration object, and to use that catheter for self-calibration. So to calibrate the imaging systems, to calibrate using the catheter inside the patient. This is appealing for 2 reasons. First, the catheter is already inside the patient, and 2, it's because it's really a local calibration. The calibration using a calibration object like this one, it calibrates volume around the patient. But if we use the calibration that is really local to the patient, we think that we have a better calibration. So using that, what you see here is that you see the 2 points here that are representing the start and the end of the balloon when we do angioplasty. So you have that. And what you see in the other side, it's the projection of those points inside with the other view. It's the epipillar line for those who are more familiar with the computer vision term. So it's a projection of this point into the other images. As you can see, in the perfect world, we would have those 2 lines aligned with the point, which is not the case. And this is the DICOM. This is the information of the parameter that is from the DICOM images. So if we do the calibration after you outlining the catheter and reconstructing all the points, you can see that we were able to correct quite well the miscalibration we had before. So this is before, and this is after calibration, where you can see that it is fitting. And we can do that repeatedly to be able to reconstruct inside the patient the volume. So we have an automatic method to detect the catheter, detect also the guide wire, and using that, we can use the first frame, for instance, to do the calibration. And once the calibration is done, we can perform the 3D reconstruction, as you can see here, and we can have, we can obtain a successive 3D reconstruction of the guide wire at different time in the sequence, and to be able to measure what is the respiratory motion, for instance, or what is the cardiac motion, or what is the effect of the respiratory and the cardiac motion on the the geometry of the guide wire. This is very nice, but how can we validate it? That was our problem. We did all this work. We worked very hard to reconstruct in 3D. We were able to generate some images in 3D with the time. But our problem was that it was very difficult to validate, where we could have a magnetic tracker, and to be able to get the magnetic tracker to follow and to induce a respiratory motion, and to see, use it in the cath lab, and go there and see if we can replicate that with the magnetic tracker. However, it's very complicated and requires a lot of efforts. So we took another direction, where we used a virtual model. And this virtual model, this is maybe my key messages that I want to give you, is that it's really helpful to grasp some concept and to be able to use the virtual model to be able to understand what's going on. And after, it's easier when you go into the real world. So we use the XCAT Phantom. The XCAT Phantom was developed at Duke University. It's basically using the Visible Human project, where they developed a simulator using 4DCT that incorporate the respiratory and the cardiac motion. And every parameter in the respiratory and cardiac motion can be changed, and it's basically a geometric model with surfaces. And using that geometric model, it's possible to take and adapt it to different patients, for instance. For our cases, what we wanted to use it to be able to adapt it to pediatric phantom, for example, to simulate the pediatric anatomy. What is interesting with that phantom is that we can simulate also all sorts of CT images. So using the phantom, it's possible to use the parameter, generate the CT-like images. Once we have the CT-like images, we can use a CT projector that simulate X-rays angiography, and that allows us to see exactly what's going on inside the coronary artery, for instance. And that's very nice, because we can use that to validate our approach. We have the ground truth 3D reconstructed of the coronary artery, or any artery that we want to reconstruct. We have the ground truth, and then we can compare the ground truth with the one that we are reconstructing, and we can see what is exactly the errors that we are committing in the perfect world, where there's no calibration issue, where everything is already controlled, but the only difficulty is the reconstruction of the anatomical structure, for instance. And that was really helpful for us to use that kind of phantom, because that allows us to validate our work and to be able to see how well we were from the truth, I would say. One of the work we did with that was 3D reconstruction. We wanted to take, of course, different views, and to be able to apply a technique called voxel coloring. So we are considering the the 3D space as a grid. And what we wanted to do is to be able to make sure that from the different views that we were able to carve the shape of the vascular structure that we wanted to generate. So what you see here is you see an example, a 3D reconstruction of the aorta using the XCAT Phantom. So we generated some simulation of the aorta with contrast agent injection. And using that, we were able to use the projection matrix of both views and to see if whether we were able to reconstruct back into the 3D space and compare the 3D reconstruction that we are using with the ground truth of the Phantom. And we can do it even using motion, which is very interesting for us. So this is an image of the cath lab we were using some time ago. And what you can see here, the patient is here. One of the problem is the ionizing radiation with fluoroscopy, with angiography and fluoroscopy. You have to use X-rays. It's really important to manage the dose due to the risk of ionizing radiation, especially for the staff, but also for the patient. So this is one work that we were interested to see if we could propose something using artificial intelligence to lower the dose or to do something a bit more smarter than just to expose the patient to ionizing radiation during X-ray angiography. So we the basic, it's to use pulse fluoroscopy. So what pulse fluoroscopy is that instead of acquiring images constantly at the frame per second, 15 frame per second or 7 frame per second, instead of doing continuous fluoroscopy, usually it's done by pulse fluoroscopy. So what it is that we are acquiring images at different cycle. And what we have is that we keep the last image hold. You leave it, we copy the frame, and that allows to avoid flickering where the frame rate is. So it's allows to have a video of the that is continuous in appearance, but allows also to reduce the number of frames that we are exposing the patient to harmful radiation. I've been told that before they were using very long time ago to evaluate these kind of techniques. They were when the fluoroscopy was continuous, they used some kind of like a metal plate, round metal plate with a hole in it, and it was rotating just underneath the fluoroscopy. So the plate was protecting the patient when it was turning around, and then it was the same effect than here. So you can have only images at different place. That was interesting, I think, to see. So our idea was to use LSTM networks for predicting the different frames of instead of copying or just taking the frame as is. We decided to divide it in two steps. One of the steps is that we were acquiring the images. So the images are coming as we go, and we train a model on it. And then we go into prediction mode, where if we collected enough data, we were able to predict how the images would look like. So instead of copying the frames blindly, we used the predicted images in time to be able to reproduce like a full sequence. We can do that since we can assume that it's a cardiac motion and it's a cyclic motion. So we can use that, leverage that to be able to reduce the number of frames that we need to have a continuous representation of a frame. We inspire us a lot from the video compression community, where they need to reproduce, to encode the images, but with as much as possible without any loss. So the idea was to take, of course, the XCAT phantom. We generated 56 patient geometries. We also had patient data set, and this is important. I think it's important if we do virtual study to, it's important to include as well patient data set to be able to confirm if our virtual model is nice. So we trained with both simulated and real patient data set. We first use MCNet, which is an architecture that decompose motion content in the same training phase. You can see it a bit better here. You take the observed frames. With the observed frames, you encode the changes in between the frames. You encode also the content. So it allows to make sure that we are considering both the motion inside the video, plus we are considering the content of the video to make sure that the content is as good as possible in between frames. That's the basic idea behind the MCNet architecture. Of course, if we just use it as is not good enough. So we ask ourselves, how can we model the shape of the vessel? One of the most used technique to do that is to use a vessel nest filter. The vessel nest filter is the vessel that enhance long and thin structure from an images. And using that particular vessel, it's very good to detect vessels into X-ray angiography images. And what we did is that we used that filter to generate a map or where the vessel would be, and we incorporated that term inside the MCNet loss. So instead of just using the basic MCNet architecture, we used of course, the gradient difference, the intensity difference, and we added the vessel nest difference in between frames to be able to see, to enforce that we're going to keep long and tubular structure in between all the frames. So that's the idea. We take the response of the vessel nest filter at time t, and this is at time t minus 1. And then if we do the difference, we have an idea about what was the motion in between the different frames. This worked because we are assuming that in between each of the frames, the changes is not that high in between the images. So here you see some example of using a right coronary artery. You have the ground truth on the left. You have the MCNet, the original MCNet on the far right. You can see that the MCNet prediction is not that good when we, as we move on into the number of frame, we see that we are degrading a lot the images. However, if we keep the vessel nest term, it's preserving as much as possible the coronary artery structure, which is what we were looking for. We can see with the more complex images. Then again, the first video is the ground truth, and the last video is the MCNet prediction. And what you see in between is the MCNet prediction, but with the constraint of the vessel nest filter. This is our second model for cardiorespiratory model. MCNet was working well, but it wasn't really developed for coronary artery. Here, what we did is that we developed a model specifically for coronary artery. We wanted to include also translation, rotation, and affine deformation, and we use coherence point drift to follow the coronary artery in time. And we use the same idea with the original images, the filtered images, and we integrated that into a deep LSTM model. So we were predicting basically the transformation parameter that we are looking for into the image. This is a right coronary. that we did using the XCAT Phantom. And the blue line is the line that we are predicting what would be the motion for the next frames, which is it follows quite well and this is a more complex images with real patient images. And you can appreciate that, although it's not perfect, but it captures most of the cardiorespiratory motion through time. And you can see here the evaluation we did with the what you see here is the translation X and the translation in Y. And what you see in dark blue is the real motion, the real translation. And what you see in green is what is predicted by our algorithm in both translation in X and Y. So the question I have is how to bring those virtual models. This is really nice. We were able to use the virtual model to validate, which is very nice. But how can we bridge that to reality? And this is something we are really interested in, and we want to really push that forward. How to bridge the virtual model to reality. This is one work we did using optical coherence tomography. Okay, what is OCT or optical coherence tomography? First of all, it's very important not to confuse it with CT. OCT doesn't have to do with radiation at all. It's completely different. It's purely light-based modality. I will show you how it works. So it's a light-based modality. It has a high resolution, 10 to 15 micrometer, very fast imaging acquisition, and it works on interferometry principles. So basically, it's a lens with a laser, and that rotates. And with that, it's allowed to acquire the inside of the vessel. With that, we can generate images that of the inside of the coronary artery, for instance. So let me show you a video that will illustrate that better than I can explain it by words. So you have here a silicon model of a coronary artery. You see the aorta here, and then you see the coronary artery. We have the catheter, the OCT catheter, that is inserted inside the coronary artery. And you will see we just have to press a button from the console, and then it will retract automatically while acquiring images at the same time. Let me show you. So you will see, if you are very, very attentive, you will see a very, very tiny, tiny, tiny light source. Let me show it again. Very, very tiny light source. This is exactly what the tip of the catheter that where we acquire the images. So with that imaging modality, it's possible to acquire those types of images. Let me show if I can start the video, and let me see. Yeah, perfect. So what you see here is the inside of the vessel. You have a cross-sectional view, just like if you were going through the vessel, and it allows you to see, you can see the different tissue inside the vessel, and it allows you to navigate really and to follow the tip of the catheter. Of course, it's it seems to be very simple, but it requires some skills to be able to acquire those images, because you need to do a saline flush. So we need to flush the blood from the section of the coronary artery you want to image. So you have to do using a saline solution. I think you have to inject it, and then you see the vessel itself, and you can see the different tissue. So the intima, the media, the adventitia. Usually for adult cardiology, we want to assess whether there is arteriosclerosis with the presence of plaque, etc. For us, we were working with patients with Kawasaki disease. So the idea was to be able to assess whether there was the different tissues, some changes in different tissues. So using that, we were able to compound each of the frames and to be able to construct in 3D a model of the coronary artery, but with the different layers. Let me show you. Yeah, exactly. This is what you have here. So we extracted features using a pre-trained model. We extracted features, and with those features, we trained a segmentation model to segment each of the different tissue layers, and using registration, we registered each of the frames inside the vessel to allow to have a nice tube and to be able to have a continuity inside the tissue structure. So if we had one area where there's a lesion, for example, we would be aligning the lesion in 3D to be able to have a full representation of the vessel. And once you have a 3D representation, and that brings me to I call it the fun part of my talk, when we are printing in 3D and we are using 3D printed models to be able to replicate patient data from the OCT acquisition. So we took a OCT acquisition. We generated the 3D. Using the generated 3D, we printed a little rod, like you see here on the top right of the slide. We printed in 3D using a resin printer with very, very high accuracy. So we printed like a stem, basically. It's just a stem that you can put into a mold, and using polyvinyl alcohol cryogel, which allows to replicate the physical property of human tissue as much as possible. So you can take that gel, and we can generate a 3D representation of the coronary artery. Of course, once we do that, we can re-image the 3D, and we can see how far we were from the images we generated. And here's some example of the result. You can see the one in the left, it's the real patient data set, and the one on the right is the generated one we had, reconstructed in 3D, and we have regenerated and we have reacquired. Of course, the images on the right is much better because it's not in the patient by itself, but it's in our phantom. But it's really promising because we can replicate basically any patient geometry of coronary artery, and we can re-image them and so on. And it allows us to better understand the imaging modality of OCT using that without having the patient, and then we can see if we can generate it inside the patient. One work we are interested in is to be able to simulate the tissue layers. In this case, we just simulated the lumen, but we have some ideas where we could maybe add some layers into the polyvinyl alcohol to generate some tissue layers. But it's still something that we are trying to solve, how to generate different tissue layers and so on. Of course, we have done some work in navigation, and with the virtual model, it's very nice to assess whether we are going to in the right direction. But with real model that we are developing, it allows us to understand a bit better what's going on into the surgical field. What is hybrid procedure? Usually, VSD are treated using a hybrid procedure when you have the cardiac surgeon and the interventional cardiologist working together. So the cardiac surgeon is doing the open heart surgery, and the interventionist has to go and it puncture the heart to access the VSD, and to be able to put a plug called an Emplatzer VSD occluder during the hybrid procedure, and after that it shuts off the VSD. But it's very difficult to assess the optimal access point. It's very difficult to know exactly where to do the puncture or where to You really need to see, to have augmented reality vision. They use navigation guidance using transesophageal ultrasound. As you can see here, the probe is very small and it's inserted into the esophagus of the patient. And it's very complicated, but it allows to have very nice images of the vascular of the heart inside and to see where they should go inside. So with our protocol, we decided to generate phantoms, including the VSD, to be able to better study how can we do the puncture and also to be able to train cardiologists. So we decided to do 3D printing then again. And 3D printing, we found out that it's very useful for congenital heart disease since the anatomical structure is very complicated, very different than irregular adult patient. So it's very valuable to have a 3D, a physical representation in hand of the complex anatomy of the patient and to be able to play with it or to study it, understand it, and then after go to surgery. So this work, we segmented the different structure that we wanted to reconstruct it. We generated a mold of a 3D model first, and then we generated a mold, and then using then again polyvinyl alcohol cryogel. We have a custom-made freezer that runs Linux with a Raspberry Pi that control the cycle of thaw and freezing. And with this freezer, it's possible to create the cryogel. So we did casting with silicon and polyvinyl alcohol to generate two representation. The cardiologist didn't like the silicon one. He didn't thought that it was really realistic, and he didn't thought that it was going to be something that he would use. But the polyvinyl alcohol was very, very, very realistic to his mind, and he really preferred that for reproducing the anatomical structure. So we went this way, and we reconstructed constructed the mold, constructed the cavities, and we generated with different layers. So the different phantoms are created using different molding techniques to be generated afterwards. So once we have the 3D model of the phantom, of course, we wanted to replicate what's going on into the OR. So we use here the ultrasound machine with the TEE probe that is being used during ventricular septal defects. We had also an Aurora tracking system for Northern Digital, where we could track the position of the probe. We could track also the needle. We could track also the phantom in real time. And we had the host computer, collecting the 3D data and so on. And we had also a 3D software that allows us to see the 3D model of the heart phantom with the real model, with the needle. So we were able to track it and to see whether we are with the right angulation to do the puncture. So it allows us to see whether the trajectory is good or not without even before doing the puncture itself. And also this tool allows us to train resident. For example, if they want to train with different type of phantoms, they can do it, and they can do it repeatedly, what we cannot do with a real patient. So we think it could be something that is very helpful for training and for also improving the cardiologist skills. And here you can see some image of the ultrasound. You have the phantom in silicone, which is not it's a bit too nice from the images that we acquired. And the cardiologist didn't find it very realistic, but the phantom in polyvinyl alcohol was much more realistic and replicate much more the what we were trying to do with the different type of VSD and so on. Of course, once we have a phantom, would be nice to have flow. So we decided to build first of all, to build our own blood mimicking fluid. So we had several recipes where we mix glycerol, sodium iodide to generate also some ions inside the fluid. For before we were using only distilled water, but the image wasn't so great. But with the addition of glycerol that replicates the viscosity of the blood, we have also the sodium iodide that allowed us to be able to measure using Doppler images, as you can see here. And of course, we had a mechanical pump to be able to have a blood flow inside the vessel. And what we wanted to do, this is something that is ongoing, but we wanted to have to use soft actuator or soft robotics to be able to generate the cardiac motion. This is something we are currently working on, but it would be nice to be able to replicate the cardiac motion and to be able to study it afterwards. We have done some work also using a stent placement of using CFD and using like a cylindrical deformation models, and we optimize the parameters. And what is nice with that is that we can generate all sorts of CFD based visualization. This is including also the distensibility of the vascular structure. When you can see you have the stenosis of the pulmonary arteries here, and you can see the pressure and also the wall shear stress of the vessel. So that allows us to provide to cardiologists all sorts of visualization that they can use to better understand their patient even before seeing the patient. And we're currently working into using that, reproducing using patient data, reproducing the exact blood flow and simulating the exact blood flow using the boundary condition that of the actual patient, and to use that for simulation. And we are now trying to print in 3D, just like I have a little small model of the pulmonary artery here in elastic resin. And we wanted to do that with elastic resin. We had also silicone. And of course, our goal would be to go for a polyvinyl alcohol cryogel, where it's the most realistic material, but also a very challenging and tricky material to work with. So in 3D printed, what we did, we use a Formlab printer for elastic resin, a little bit like the one you see here. And this is the example you have on the left. So we basically just took a STL file of the pulmonary artery. We send it to the printer, and it printed it a copy for us. The second one is a bit more tricky. We did print into a soluble material because we wanted to have the lumen inside the vessel. So it's a soluble material. It's PVA filament. And using that PVA filament, we dip it into silicone, and a little bit like ice cream. You know, when you dip an ice cream cone into chocolate, we dip it in the silicone, and then it generates a copy. The silicone sticks onto the PVA filament, and then we let it dry let it sit down, let it cool down for a while. And after that, once it's all set up, we put it in water, and then we have a replica of the pulmonary artery. For the other one is much more complicated. For the PVA one is much more complicated because we need to have a mold, and using that mold, we need to put it in the freezer and demold it. So it's a very, delicate steps, but we were able to do it, and the result was quite pleasing. Then again, you will see I have some video of that. We did build our own pump using stepper motor, microcontroller, Raspberry Pi, and we have an industrial pump here that pumps fluid, and the microcontroller is controlling the speed of the pump. So we are able to generate all sorts of pulsatile blood flow inside our 3D models, and it's controllable. So we can just take the patient flow from the pulmonary artery. We take that, we generate like a curve of the flow we want to represent. We send it to the Raspberry Pi, and then we can reproduce patient-specific pulsatile motion using that pump. It's very homemade. I did that in my basement, but it's very functional, and it was quite a nice project to do. And you can see some example here. This is the silicon one. Right? You can really see that there is a pulsatile motion inside the blood flow, and this is the PVA one. The PVA one is a bit more thicker. We designed it a little bit thicker to be able to have something that is easier to demold, but we are in the process of improving that part. So that brings to my conclusion, and I think I'm not so bad on time. So I just wanted to say that for us, studying cardiorespiratory motion is very important because it's very challenging, especially when you're working with pediatric populations such as CHD. I think that virtual trials with real trials or real simulation mock-up are very important to gain insight about the clinical technical problem. And I think they are gaining much more interest into the, if you want to make the standardization or homologation of products and so on, they are becoming more and more interesting and recognized for their value. And I think it's very important since it allows to bring down the cost of research while maintaining the quality. Using AI, we did use AI a lot. I think it might provide new tools to improve either patient care or current way of doing things, but we need to be careful and then again validate with real patient or with real models. And as you may suspect, experimental setups are really important to confirm, what the model you are trying to study and so on. I just wanted to share one last thing. We did some work also for the respiratory masks. We did some 3D simulation using finite element analysis and machine learning. And we had one project where we took a lot of virtual models from the computer game industry. We bought a database of faces that are used in 3D games. And we printed it in 3D to validate our approach using the respiratory mask. So to test it on different, morphology, anatomy, and so on, old, new, different ethnicity, and so on. So it's very important to do that, I think, to really capture, the large amount of data that we have when we're dealing with personalized human models and so on. So that's it. Thank you very much for your time, and I will be very thrilled to answer any question you might have.
Dr. Duong, thank you very much for such an interesting talk addressing.
No se te oye, Víctor.
Hello, hello. Oh, that's the sound. Hello, hello. Am I back? Yeah. Okay. Thank you so much, Dr. Duong, for such an interesting talk. It addresses a very relevant topic, and I am sure we are all thrilled by all the technologies you have talked to us about. So now let's move on to questions and answers round. We have a couple of questions, and I will start in the order that we received them. First one, would it be possible to apply or reproduce this technology for aneurysm identification?
For aneurysm in where, in the brain or?
Yeah, in the brain.
I think so. I think so. As long as we have images to use to leverage, and we can segment the anatomical structure, I think we can do that. I think it's not a problem. The problem still again is the segmentation, and we have been working a lot with different segmentation techniques in the past years, and they're not perfect. So that's why maybe the human interactions becomes very important, where you can use, let's say, an automatic segmentation model, and once you have the automatic segmentation model, you can correct or inject the the information you want to be reconstructed. Let's say it's an aneurysm, or it's a specific, anatomical structure you're interested in, and then you can generate different, parts of what you're trying to do, and then you can print it and you can represent it. Yeah.
Thank you so much. Next one. Leiner Barba says, thanks, Dr. Luc, for your nice talk. I have a question. Data used to build the virtual models have been acquired from normal patients. What would happen if a cardiac arrhythmia is present? Cardiac motion changes in some pathologies? Those are like three questions in one, but sorry.
It's very good questions. Usually for a virtual model where, of course, it would be nice to have a personalized one that is very close to the patient anatomy. And this is what we are working on currently. We want to be able to use, for example, the XCAT Phantom, and to be able to personalize it to our data. And we have the XCAT Phantom, they have done some work where they have different patient anatomy, but for different age. So they have, let's say, different from newborn to adult. But the problem is, I think, really to be able to personalize it to a specific patient imaging. And I think that's something that we're trying to solve, where we're working on that, and that would be nice, because then we could replicate as much as possible, including arrhythmia, including that has a really specific, that really represent the specific patient anatomy. The XCAT Phantom, by the way, is very accurate. We did some work where we were interested into seeing the distensibility of the coronary artery using the XCAT Phantom. At first, I was, I would say, hesitant. I didn't thought that the Phantom would be able to be as precise as, modeling the distensibility of the coronary artery. But to my surprise, we were able to measure it. So that gives you an idea about how precise it is with but we can personalize it further with the real patient imaging. That would be fantastic.
Thank you very much for the answer. Next question is, are there some opportunities for students from UNAM to work on the projects you talked to us about?
If there's any opening, if there's any project right now, well, we have Melissa that is working with Jimena and Boris, that is working with us from UNAM. So yes, of course, there are some possibilities, and we are always open to welcome new people from Mexico.
We invite our audience to copy the email address of Dr. Duong, which is in this slide, so don't miss it. Okay. For now, these are all the questions we have. I'm not sure if Dr. Boris wants to.
I have a question, if I may. Look,
Yeah, sure,
first of all, thank you very much for this extraordinary talk. It's very illustrative, very exciting to first of all to see that research is really being applied in real cases. No, it's the kind of work you do is really inspired based on necessity, on real necessity about patient. No, that's very important. And I when you showed the 3D model of the heart, it came to my attention that some time ago we had the inquiry from some medical doctors here at Mexico who are doing open heart surgery on children, and they do surgery on children who have severe deformities, congenital deformities, and although they have the computed tomography images and they know more or less how the deformity it is, they told us that it's not the same thing to see to have the information from CT, because when they open the patient, they find things that they were not expecting
Yes.
to do,
Yes.
and they have to solve them at the moment because they have the patient opened. So they said that for them it would be very, very useful to have 3D models. 3D models in some material like the one you showed, which is kind of soft material, and they prepare the surgery before doing the actual surgery, no? And I don't know if you had you've had with a similar opinion from the medical doctor you work with, because I suppose that if it's the case, they would be asking you the same thing, no? To build these 3D models of children with deformities who they have to make surgery.
That's a very, very, very good question. From the literature, um, I found out that one of the application of 3D printing is really into congenital heart disease. It's amazing how this technology was welcome into that field due to the complexity they have to face to see the patient anatomy and so on. I think when the anatomy is predictable and so on, they don't really need assistance from my experience. They don't really need some experience. They know how to navigate. They know how to so the the 3D printing of a model is not that much of a issue, but in complex cases, it's very important to understand what is connected where and so on. So the connectivity, I think that really helps to assess that, and that's really helpful, especially when they have to communicate with the family as well. So as from my experience when I was showing that to doctors, the first reflexes that they had that, oh wow, that would be nice to have that to explain to the family what's going on, for example, or to the patient itself to show to the patient, okay, this is your heart, and this is where you see that there is a problem here. My understanding is that when you show that on the computer screen with the CT and all, of course, if you are used to see CT or X-ray radiography and so on, you understand you have a mental model that already created for that, so you can extract the information and understand what's going on. But if you're a patient and you don't know how to read CT or X-ray, it's much better to have a 3D model that you can touch, you can move, you can say, oh, okay, this is my pulmonary artery, and this is how it's shaped. And then it creates a better understanding of what's going on, or where also for the clinician, he can better explain the procedure that it's going to do. I know that some centers in the States, they are doing that routinely to each of the cases. They are using 3D printing, but it's a matter of it costs a lot of to be able to do the 3D printing and to generate the models and so on. But in the US, they are doing that, I think, in some centers. Um, it would be nice that it's going to be more, um, spread. But I think that really can bring another perspective on what's going on when you have access to 3D printing facilities. One other thing I wanted to say, I remember, is about doing it in-house versus, subcontracting a company and so on. And from the same hospital that I mentioned in the US, they say it was better for them to do it in-house since when they wanted to have corrections of the model because they're going to operate tomorrow or something like that, it was easier to communicate with the in-house team and to say, okay, well, we have this patient. Can you reprint, or can you do some modification, or can you print additional? So they have the better control on the whole pipeline of the 3D printing. I hope I was able to answer your question.
Yes, yes, yes. Thank you. Of course. Thank you. Thank you.
We have received 2 questions more, Luke. You
good.
tell us if you want to address them by now.
Yes, of course, if it's
great.
possible.
Here they go. The first one is from Atocha Liceda. She says, could you please expand on the importance of human-computer interaction? In what situations is the input of a human relevant? Are there any decisions that are left to the automatic systems?
Another great question. I think computer system can assist. I think they can assist. They can help to the decision. But then again, I'm going to take one of the discussion I had with the clinician. One of the clinician told me that and really struck in my mind. He told me, the day that you will have a software or, AI or something like that that will do the job for me, then my brain will shut. My brain will shut. I will not think anymore, and I will just, follow what the AI is telling me because I need to focus on the rest. So I think this is important. Where to put the human in the loop? I think the human should always be in the loop and should be there and the AI or the computer should be there to assist, to provide guidance or to, but it's difficult to say that it's meant to be to replace the human. Maybe I know now it's possible to do robotic surgery with very, very high precision now that we weren't able to do that, 10 to 20 years ago. But then again, it's assistance. You have the system that assists the surgeon, and it's still a human that is operating. I think it's important to have the human in the loop.
Thank you so much, Dr. Luke. And the last one. Thank you very much for the interesting talk. What image modalities do you recommend to monitor the blood flow in 3D models?
It is it's a difficult question. It is a very difficult question. For tracking the blood flow, we use the echo. I think echo is nice. We did some study using Doppler. It's very nice, but it's very difficult sometimes to acquire the images and so on. What I like with echo is that it's flexible, it's easy. We have one in the lab, so it doesn't require to have, a lot of complex infrastructure to be able to acquire images. But I know that there are some, other imaging modalities that allows to see the blood flow and to quantify the blood flow. MR, for example. I think there is some very nice work that is being done into that direction. But from my opinion, I think echo is still a very simple, very interesting way of measuring the blood flow, and also it can be done, simply with a routine exam. So this is something I think it's important to think of when you want to develop a new test or a new imaging modality. Yeah.
I have another question, Victor. To Luke. Well, more than a question, don't worry, Luke. It's not that heavy. I wanted you to talk about your research group. The last time I heard about your group, it's a very heterogeneous and multidisciplinary, the nature of the people, no? That's what I noticed. And they can come from very different areas, not only science or computer vision, physics, bioengineering, but others, no, that I saw. Can you tell us about what's the advantage of having your group, or talk about what are all the interactions with also with medical images?
For me, working with other type of with people outside of my field, it's by design. I always did that. It's something that comes to me naturally because I remember at the beginning I worked with orthopedic surgeon. I worked also with all kinds of people from different background, physicists, mathematicians, physiotherapists, a lot of people with different backgrounds, and that allows me to see that everyone has a piece of the puzzle. But if you were able to bring all the piece of the puzzle together with the different specialties, and you're able to solve a lot of problems. And I think this is the way to go, because it's almost impossible by yourself to be able to know everything. I'm I'm a computer engineer, and I know a bit about software and a bit about hardware, but I don't know much about biology or chemistry. But I work with people that had the proper background, and I think that that's the key to complement what you don't know about and you want to learn. But it's much easier to work with other people than to learn by osmosis. And that creates a very interesting and dynamic synergy in the team. So that's my opinion. And I think it's the same also with the different type of people from different background. I think that's very good to have that. And it's really enrich, like the research group and so on.
Thank you. Thank you.
Yes,
Dr.
thank
Duong.
you.
Well, I now give the floor to Doctora Jimena Olveres to dismiss this session.
Okay, well, thank you. Thank you, Dr. Luke. It was a wonderful talk. I think that is it's very important, this area of medicine, and I really hope that for everyone can see the value, and I encourage you to start exploring on your on this area also as well. This is, as you can see, there are lots of things still to be done, and it's in constant development. So we look forward also to meet you again, Luke. Thanks a lot for the very interesting talk. And everyone, please, we will welcome you for the next seminars. We are very happy that we got such a large audience. So thanks a lot.
And thank you very much for having me. It's a great honor. Like I told you, I greatly appreciate it.
Yes, thank you. Thank you, Luke. Well
Thank
done.
you. Bye
Thank you
bye.
very much, Luke. Bye-bye. Thank you, Luke.
Thank you very much, Boris.
Thank you, everyone. Bye.
Bye-bye.